All right, welcome everybody. It looks like we have about 60 some participants today, which is great. Thank you all for joining us for another one of our installments for our town hall, Be Well, Virginia. We're thrilled that all of you keep coming and listening to us. We love educating and we love making sure that we can do what we can to keep you all safe. So this has been really fun for me, and hopefully it's been educational and informative for all of you. And so, as I said before, we're going to keep doing these as we can. Today we're going to continue with giving you more updates on the latest with the coronavirus pandemic. But I'm sure after 3 months of going through this, we're all probably starting to get a little bit of COVID fatigue. It's hard after staying home all this time and reading almost nothing but this. So, it's important though that we continue to give you the information, because even though we might get tired of it, we're still really in the thick of it. It's not going away anytime soon, probably. And so we want to make sure that we keep you informed and keep you energized to make sure you continue and don't let down your guard. Continue doing the things that you need to do to keep yourself safe. With that said, we are going to try to sprinkle in some other topics in the next coming weeks or so, if we can. We haven't exactly figured out exactly how we're going to do that, but we're going to try to still talk about COVID, but throw in some other topics as well that might relate to that day's topic. So, because other medical conditions, as we've said, haven't gone away. Heart disease hasn't gone away. High blood pressure hasn't gone away. Diabetes is still around. Not just because there's a pandemic doesn't mean that they've disappeared. So we want to start addressing some of the other chronic medical conditions and other issues as well, and start sprinkling that in to our town halls in the next few weeks. Right? So hopefully that'll keep things a little more interesting while still keeping you up to date on what's going on with the coronavirus. Just some updates for what's going on in our area. So as of today, it looks like over the last week in Virginia, the trend for positive cases, deaths, hospitalizations has started to come down a bit. It looks like there is a trend over just the past week. In the DMV area or immediate area, Northern Virginia, DC, and Maryland, it's a little more flat with maybe a slight trend towards decreasing, but going hopefully in the right direction. With that said, obviously, there's a delay to these numbers. So we are delayed about 5 to 10 days because it takes that long after exposure to turn positive and show symptoms. So we're a little bit behind of what's going on, and we just opened up in the area over the last weekend with phase 1 in Northern Virginia, and obviously with the protests going on downtown, we might see a spike of numbers starting to go back up again in the next few days. So we'll have to wait and see. I hope that's not the case, but it wouldn't be surprising if that is. We'll just try to keep an eye on the numbers. But with that said, obviously it also means that you all have to stay vigilant and keep doing what you need to do to stay safe. And that's wearing masks, being physically distant, obviously, and washing your hands and using hand sanitizer very, very frequently. So those basic things make a big, big difference. There was just an article this week in The Lancet, which is a great article that quantified the benefits of wearing a mask. And it looks like the benefit of wearing a mask, even just a cloth mask or a surgical mask, not an N95, seems to decrease the risk of transmission between 60 to 80%. So really, really impressive numbers of how important the mask is, both in a hospital setting and in a community setting. So really encourage you to continue wearing masks whenever you're around others. It does make a difference. Don't let your guard down, please. Also, you may know that we moved into new offices. Our new office is beautiful. We've been there about 3 weeks now and starting to get settled. We just got new furniture today and it looks great. The office is big. We have lots of exam rooms, lots of waiting rooms, and we're doing everything we can to keep the area safe for all of you. So we're trying not to have any more than 2 or 3 people or 2 or 3 visitors in the office at any given time, so everyone can have their own exam room. And even beyond that, if you have an appointment, we're going to try to take you straight back once you check in to the exam room so that you aren't spending any time in the waiting room. We ask that you all come in with a mask and that you wash your hands or use hand sanitizer as soon as you walk in the door. And our nurse will be at the front desk, or receptionist will be asking you to do that, and we'll provide you with a mask if you don't have one. But we want to make sure for both your safety and ours that you all do that. We are also now starting to schedule our lab appointments. So we used to have a walk-in system where you just walk in anytime, but unfortunately we had an uncomfortable number of people showing up at the same time one day recently. And so to avoid that, we now ask that if you need to have your blood drawn, to also call and make an appointment for that like you would for a regular visit, and we'll schedule that so we can keep as few people in the hospital, in the office as possible, okay? So just call our front desk, the main number, and they can schedule for a lab appointment if you're due for that. And finally, for those of you who signed up for Age Proof, it seems to be going really well. Age Proof Your Body, everyone has been very happy about that and excited to do it. It's a great program. If you haven't signed up for it, you're not too late. Just because you missed the first class doesn't mean you can't continue, you can't sign up again. Each class doesn't necessarily build on the other one. So feel free to go to our website and look at that and get some exercise. Helps you keep limber and keep strong in the comfort of your own home. So please take a look at that too. All right, so now we're on to our main event. Today, I'm very happy to welcome Dr. Ian C Mungle, who is an infectious disease doctor with Virginia Hospital Center. He's been there for about 10 years. Dr. C Mungle is originally from Trinidad and received his medical degree at Ross University in New Jersey. Then went on to do his residency in my hometown of Pittsburgh, Pennsylvania at Allegheny General Hospital, and did his infectious disease training at Hahnemann University in Philadelphia. Dr. C Mungle has been recognized as a top physician by Washingtonian for each of the last 5 years. And that's a very prestigious award for anybody to get even once. So for him to get it every year for the last 5 years is an extraordinary feat and well-deserved. He's also been recognized by Northern Virginia Magazine multiple times as well. And if you ever look online, you can see he's got fantastic reviews from his patients. He is just really a very knowledgeable and extremely warm and caring physician who takes outstanding care of his patients. I always know my patients are going to be well cared for if they're going to see him. But the real reason I invited him today was because I was so taken by him the first time we had an interaction. It was about 4 or 5 years ago. I was teaching at Virginia Hospital Center, a team of students and residents from Georgetown, and we had this one case that was in the hospital with clearly an infection, but nobody really knew what the infection was. So it was an interesting case. And Dr. C Mungle was consulted on the case, and he happened to walk by while we were teaching. And so we stopped and asked him some questions, and he became so engaged. He just lit up to talk about this case. He was clearly so enthusiastic, so interested, and so passionate about what he was talking about. He engaged the students and the residents. He took about 30 minutes out of his time to talk to us and go over the case and teach every point that he could think of and all the possibilities. And he was so passionate about it that his sentiment was, dare I say, infectious. He even took us down to the microbiology lab to show us the slides. It was just a really great teaching experience. And it was so he clearly loved what he did so much, was so enthused about medicine and about infectious disease that it was obvious that he chose the right profession and was phenomenal at what he did. And so, I was really taken by that experience with him, and he hasn't let me down ever since. He's been really great with the patients and clearly is just very, very passionate about what he does. So thank you, Dr. C Mungle, for that experience, and thank you for joining us today. Really happy to have you here.
Thank you. And thanks for that introduction. And I'm happy to be here to try to answer these questions. I know we're in a kind of unprecedented time, and there is probably a lot of confusion about a lot of things pertaining to COVID. So hopefully we could clear some things up.
Great. Yeah, right. And hopefully, I'm sure you can give us some information. So we're going to go, we deviated from this format for the last couple of town halls, but we're going to go back to where we are just going to answer a number of the questions that people sent in. So I'm just going to ask you these questions, and hopefully you give the answers that the people that are burning on their minds. So the first question has been a lot of questions about the new antibody tests and testing in general with COVID. And so in general, there's a number of antibody tests out there. Can you talk about these and tell us about the sensitivity and how good these tests are?
Right. So yeah, this is an important question, and it's getting a lot of press. There are a lot of antibody tests out there. And unfortunately, because we're in this pandemic, we're having a lot of tests sent through the FDA, essentially on like an emergency use authorization. If you go on the FDA's website, you're going to see a few of these tests, and they list sensitivities and specificities of 99, 100%. But typically, when a test goes through the FDA, it takes about 8 to 12 months for it to be truly validated and tested. And so we don't really know if the performance characteristics of these tests are truly as accurate as these companies are suggesting. Here at Virginia Hospital Center, we are affiliated with Mayo, and we do have a antibody test through Mayo. Mayo is a pretty good lab. It's a world-class lab, really. Most of the sensitivities and specificities of the tests that you're going to see, they're going to say 99, 100%. And that sounds great, but if the prevalence of the infection in the community is less than 5%, let's say, you're going to have a lot of false positive results with these antibody tests. So unfortunately, there's just a lot more questions than answers when it comes to antibody testing. Patients might say, well, I think a month ago I had some symptoms. I think I had COVID. Let me do an antibody test. The antibody test may be falsely positive. And so the question is, how do we truly interpret those results? There are also a lot of other questions with immunity, right? So if your antibody test is positive, what does that really mean? Does it mean that you're immune? We don't know. If you're immune, what titer or level of antibody do you need to confer immunity? We don't know. If you have immunity, how long does it last? 3 months, 6 months, a year? We really don't know. So we need these observational studies to be done, and that typically takes up to a year. What we do know right now is there's an animal study that was done with rhesus monkeys that showed that when they were re-challenged and they had IgGs, they seemed to be immune. And what we know from SARS-1 and MERS is that typically you have neutralizing antibodies and immunity for about 2 to 3 years. So it's reasonable to assume there's probably immunity if you had COVID before, but we still have a lot more questions than answers, and we don't know which of these antibody tests is actually an accurate one. If you get an antibody test and it's positive, is it truly positive? So you're going to see a lot of sensitivity and specificity of 99, 100%, but you have to know how to interpret that based on the prevalence of the infection in the community. Because if the prevalence is low and you have a test that's very specific, you may have a fair amount of false positive results, and then it becomes difficult to interpret that information.
Right. Yeah, one way that might be easier for people to look at it that I've been telling my patients, because I've been getting this question a lot, is let's say you have a 99% test, 99% sensitive, you have a 1% false, that's a 1% false positive rate. Yeah. It's awfully good, or specificity, because you have 1% false positive rate. But if you only have 1% of the population with the disease, then you actually only have a 50-50 chance as to whether a positive test is truly positive. There's exactly. A 1% prevalence and a 1% false positive. Then what do you do with that result? It's hard to know.
Yeah, it is. And so, we need more time to really get data to determine which is the best test. Is this test truly a good test? And if you have IgG positive, does it really mean you're immune, and for how long? And that information, unfortunately, will take a little more time for us to collect.
Right. And I'm going to veer actually from the questions, because one other thing I wanted to ask you is, can you just talk a little bit about your experience at Virginia Hospital Center and what it's like taking care of COVID patients there, and where they stand right now at the hospital?
So yeah, initially a few months ago, obviously, we started to see a lot of numbers, a lot of patients being admitted. And at one point, we had to make a lot of changes to the hospital. So we had essentially a COVID floor where we would try to put all the patients with COVID just on that one floor. As we tried to take care of patients, we then had to worry about our PPE. Did we have enough supply? And how to stretch our supply. So could we reuse gowns, and we had to make a lot of decisions like that. Unfortunately, when we see patients in the hospital, they're sick. And so, a fair amount of patients had to be transferred to the ICU. Patients have been intubated. We've had some data to suggest that when you prone patients or you turn them over, it actually helps. And so over the last month or two, we've actually evolved with the kind of things that we offer patients. We prone patients. There's data on blood clots that we see with COVID. So now we have an anticoagulation or blood thinner kind of policy. So at one point it was fairly intense. I mean, and there's obviously a lot of anxiety and people are worried, and going into a room with a COVID patient and you have to be gowned up, gloved, eye protection, surgical mask. People were really worried. But as with everything, as you see more patients, you become a little more comfortable and you understand the science and the transmission of the infection. I think, we grew in confidence as to how to take care of patients. And so now we're seeing less patients in the hospital. We have probably around 50 patients. We had as much as 100, 110. And so, as you mentioned in the introduction, we're seeing cases coming down in the community and we're seeing that in the hospital. And the hope is that that's what we continue to see.
Great. And yeah, that's really interesting. I saw that there was a study looking at proning not in the ICU, that could even have some benefit. I thought that was really fascinating.
Yeah.
I don't know if you were aware of that one, but yeah, it's interesting. And can you speak about the valve masks? I don't know if anybody has seen these. A lot of people are having these N95s that have these little plastic things on the side or in the front, and that's a little valve. And those masks are N95 masks, but they're really made for painters or people who are exposed to particulates, not necessarily viruses. Can you speak to the efficacy of those masks when it comes to COVID?
Sure. So the first thing I should say is we should all wear a mask, right? Especially when we go out, because a mask is better than no mask, right? An N95 mask is probably a little better than a surgical mask, but even a cloth mask is going to protect you, right? Think about why we want everybody to wear a mask. If I'm an asymptomatic carrier, when I talk or breathe, exhale, I could be expelling particles, viral particles in the air. And so me wearing a mask is to protect you. If you're wearing a mask and you're an asymptomatic carrier, you're protecting me. The issue with valve mask is when you exhale, the valve opens. And so your secretions go out into the atmosphere. And so you're not protecting somebody else when you have a valve mask. You may be protecting yourself, but if you're an asymptomatic carrier and you exhale, that valve opens, you breathe out. If you are expelling virus, then you're not protecting anybody else. So I would not recommend a valve mask for that reason. We want to wear a mask because if everybody's wearing a mask, it protects each other. My secretions are captured if I'm wearing a mask. Your secretions are captured if you're wearing a mask. And by doing that together, we protect each other. So I think a valve mask probably would not be the best thing because, again, it doesn't protect everybody else from your secretions.
Right. And I think a lot of people just weren't aware of that. I certainly wasn't even until it was brought to light like last week or two. So yeah, we do ask that if you do come to the office, really anywhere, probably obviously a cloth mask or a surgical mask can be better, even though you've been told repeatedly that N95s are better and it protects you. If we protect everybody, then it's no longer an issue. So we do ask that you don't wear a valve mask out in public. So,
yes.
Hi. And this is a question that we've gotten repeatedly over and over again. What is a safe way to see my extended family and friends?
I know. So this is a really important question. And there's a great article written, I think it was in Vox, which actually looked at risk, okay? And I think the most important thing to remember about risk is it's not binary. It's not all or nothing, right? The way we have to assess risk is it negligible, low, medium, or high risk, right? So the only way you could have zero risk is if for the entire year you stay home, you lock yourself at home, you don't go out, you don't see anyone, right? But that's just not feasible. We're social animals, we need to see our family. And so there is going to be some risk if you decide to see family, but you then have to determine how can you minimize that risk. So I can't say that you're going to have zero risk, but there are a couple of things you could do. So for example, let's say you're going to see your extended family, your parents or something like that. For the 2 weeks before you see them, you should be very careful, right? That's the incubation period. Try not to, do anything you don't have to do, visit people or have people visit you that, isn't necessary. Take extra precaution for that 2 weeks before you visit them. You feel healthy, you're not sick, you have no symptoms, then you go visit. If you're going to visit for a day, let's say, and you can visit outside or on the patio, you could kind of remain 6 feet apart as best as you can. That may be better than having a huge family gathering with like 20 people indoors, right? At some point, however, you're going to have to just make a personal decision about what you think the risk is, and then determine, if it's worth it to go see extended family. That's the best that we can probably do, to be honest. It would be wonderful if we could test everybody every day, but even that is, difficult to interpret, right? So I would say for 2 weeks before, take extra precaution, be very careful. If you make sure you're not symptomatic, and if you do visit, try to see if you could visit in a setting where you're more outside in the open on the patio, because your risk is lower when you're outside compared to indoors with large crowds.
Great, that's really helpful. Yeah, and and it's hard and it's scary, but really we all make these decisions like this, the risks decisions every day, all the time. If you fly on a plane, you're taking a risk. The risk is small, but you feel that the benefit is worth it. When you cross the street, you're taking a risk, but the benefit of being across the street is worth it. Anything we do has risks and benefits, and so you weigh them. And so it's a very personal thing as to how you feel about your risk of going to see your family. Obviously, seeing family is important, and there's a point where you just are willing to take that risk. But anything you can do to keep the risk down is worthwhile. That's great. That's really helpful and important question. All right. So the other one that everybody always is asking about is, what are the current treatment options? How good are they? And are there any other ones that are coming down the pipeline that we haven't heard about yet?
Yeah, this is also a good question. So I think the most promising therapeutic option we have right now is remdesivir, and everybody probably has heard about that. And so there is a study that came out with about 1,000 patients that showed that remdesivir decreased the days of hospitalization, 14 versus 11. It was remdesivir versus a placebo. And that was statistically significant, so that's good. And there was a trend towards a decrease in mortality. And the study was stopped a little early because once we saw such benefit, we had to give everybody the remdesivir, right? So the preliminary data shows that. And we're waiting for the final data to see if there's a mortality benefit. And that was done at the NIH. There's another study that just came out that looked at 5 days versus 10 days of remdesivir. And 5 days seemed to be as good as 10 days. However, the people who got 10 days in that study, they were a little sicker. So even here at Virginia Hospital Center, if you're in the ICU and you're intubated, we're probably going to give you 10 days. But everybody else could probably get 5 days. And that's important because if remdesivir is showing promise, the issue with that is we don't have a lot of remdesivir, right? So we're getting some from the manufacturer. So if we could use 5 days versus 10, we could actually double the amount of remdesivir that we could use. And I think as part of a strategy, as we open up society to say it's okay if you go out, if you start going back to restaurants and stuff like that, we need to have therapeutic options. So if people get sick, we know we have something we could offer them. So remdesivir seems to be the most promising agent, but we still have a lot of data pending. Now, remdesivir is an antiviral. It works on stopping the virus from replicating. Most of the other medicines that I'll talk about, it actually works on your immune system. So steroids, there are some antibodies, convalescent plasma, which is supposed to, have antibodies from people who had COVID before. The hope is that that helps your immune system fight, or if your immune system is overactivated, steroids and these other anti-inflammatories kind of calm down your immune system to try to help you get through the infection. The data on those actually still pending, but we're not seeing results yet, right? We still have to wait on some of that data. Convalescent plasma, there's a study out of Mayo about convalescent plasma, and we're actually giving convalescent plasma here at Virginia Hospital Center. So we hope to get some data about, if it's useful. And the hope is that people who had COVID, they have antibodies, we get the plasma, we give it to patients who are infected now, and it may help their immune system fight the infection. So we don't know if that works. When you look at data about convalescent plasma from prior studies like influenza and Ebola, it didn't really show much of a benefit. And I think that's probably because plasma is something you have to give very early on. You have to actually have those antibodies already circulating, before you get the infection. And that could be one reason why plasma studies in the past, at least, have not really shown much success. But we don't know with the study we're doing here at Mayo if it'll show some promise. So here at Virginia Hospital Center, we have a convalescent plasma study. We had the remdesivir study. We closed that study because now we're getting remdesivir as an emergency use. And so we do have, some remdesivir. And when patients get admitted, we're giving them both. So that's what we're trying to do now. Now there's let me just talk a little bit about hydroxychloroquine. There's some data about that. And there's an initial French study with about 30 patients, but that study had a lot of flaws. There's a bigger study done at the VA that showed there was a little more mortality associated with hydroxychloroquine. So until we get a big randomized control trial to show hydroxychloroquine really does have some benefit, right now we really don't have any evidence that it worked. And I think the risk is probably a little higher than the benefit as of now. Hopefully, we get a bigger trial that gives us some more information. But to answer your question, really, convalescent plasma, remdesivir, those seem to be the more promising therapeutic options.
Right. Yeah, there's a lot of news reports. You hear all kinds of things like ivermectin, ranitidine, all these other things, but none of them have really shown true promise just yet. So hopefully it would be nice to have something so prevalent and so cheap and so common that we could use, but nothing really has panned out yet. The other thing is I mentioned that study in the Lancet about, I don't know if you're aware of that one, but basically it mentioned about eye protection. And so can you speak about eye protection and whether it's worthwhile outside of a hospital setting?
Yeah, that's a good question too. So, in the hospital at Virginia Hospital Center, now we've moved to using eye protection when we see every patient. So we essentially wear a mask and we wear eye protection. Obviously, if we see a COVID patient, we have a full PPE. The thought behind that is because, the virus, if it enters any of your mucous membrane, the eyes, nose, ears, then potentially you could become infected. Now, it's a little different when you're outside, when you're in the environment, when you're not in a hospital setting. There are a lot of different shear forces on the virus, humidity, UV light, wind. And so if you have eyewear and you want to wear it at home, it's summer, you wear sunglasses, or if you normally wear glasses, that will offer some protection. But I don't think in the outpatient setting, you really need to worry too much about eye protection. I think wearing a mask, social distancing, washing your hands a lot, and really not touching your face, those are probably the 4 things you can focus on. And I think that data from Lancet, I can't remember if it was inpatient or outpatients that they actually looked at. Here we're doing it in the hospital, outpatient setting. I don't think it's absolutely necessary, at least not as I would recommend wearing a mask.
That's very helpful. That's great. The other thing that's come out recently also is that the concept that COVID is actually not a lung disease, but a blood vessel disease.
Yeah.
It's a really interesting concept. And can you speak to that and why that might be important?
Yes, so there's this study in Lancet that actually looked at this. And the interesting thing about that study was they actually took pictures, micrographs of the blood vessel wall, the endothelium, and they saw a virus in there. And so that's evidence that the virus probably affects blood vessels, right? The interesting thing about COVID, even though, it's related, is a coronavirus that's related to SARS and MERS, it's its own virus. I mean, there's so many unique things that we're learning about COVID that, you know, we haven't seen before. Even the data out of China. If you think about this Kawasaki-like syndrome that we see in kids, we never saw that from the data in China. Strokes and blood clots, especially in younger patients, something we never really saw from the data coming out of China. These are new and interesting and intriguing pathophysiology that we're learning about the virus. And so it could very well be, you know, you hear about COVID toes, and you hear about all these other atypical findings we see with COVID-19. It could very well be that the virus leads to such high immune activation that it leads to damage of endothelial cells, it leads to damage to the cells in the lungs. And that data is pretty striking, that it could be in blood vessels. It could probably be one of the reasons why we see blood clots. So yeah, there's still so much we have to learn about this virus, but that is intriguing.
It is, and it explains a lot too. As you said, the symptoms that we're seeing,
yeah,
and also that the fact that we know that it goes in through the ACE receptors, which is found in the vessels, and so
exactly,
it could also lead to some interesting treatments too in the future.
Yes.
Yeah, great. All right, and then somebody asked, says, you know, asymptomatic cases are quite prevalent, and there's some estimates of up to 40% of people are asymptomatic. They want to know, do you think will affect, I think you touched upon this to some degree, but they want to know, will we eventually have sufficient ability to test people in the community so that we can catch cases early, focus on them, and quarantine people in a way that we can do this on a regular basis, or keep healthcare people safe? Basically have enough testing to tamp down these outbreaks.
Yeah, I think, you know, one of the problems that we have encountered with COVID here in the US is we didn't really have a strong national testing strategy. And that has really led to, you know, at least initially, the first couple of weeks, a lot of issues. The population of Northern Virginia alone is about probably 3 million. I looked this up when I was researching these questions. The population of Virginia is about 8.5 million, and we're doing about 300,000 tests a day in the US. So if you look at those numbers, we have 3 million people here. It's going to be logistically difficult to test everybody once a week. I think it's just that we're not going to have enough material, enough swabs, enough of a capacity. You know, when we first started testing, we were just getting the tests done through the health department. Then eventually the commercial labs like Quest and LabCorp, they started doing the tests. My first test I sent to Quest, I got the result back in 24 hours. About a week after, I sent a second test to Quest. It took 5 days. And then, you know, we were sending more and more tests to Quest, sometimes up to 8-9 days it took to get the result. That's because after a while, everybody just started sending tests. So we don't have the capacity to test everybody like that. What I think would be more useful, and to be honest, probably we don't have to test everyone. What I think would be more useful is testing certain people. So people who work in groceries, for example, they're high risk. I can see a strategy where we test them every 2 weeks. Healthcare professionals, first responders, people who work in a hair salon, right? People who are going to be in high risk jobs, where you're going to be seeing a lot of people in the community, you're going to have close contact. I mean, we're not opening up like massage parlors and stuff like that, but if we do eventually, that's a high risk type of job. So if we could test these people every 2 weeks, that may be beneficial. Can we test certain people, like people who have high risk, like if you're over 65, right? Can we test you on a regular basis every 2 weeks? I think that may be something that would be worthwhile. But to be honest, I think logistically, it's going to be difficult for us to get to a place where we could test everybody once a week. It would be great. And I think we do need to focus on testing as much people as we can, because that's the only way we're going to pick up asymptomatic carriers. If 40% of people are walking around who have COVID and they have no symptoms, they're infecting on average, if they're not wearing a mask, 2 to 3 people. That's known as the R naught of this virus. That's the amount of people you could infect if you have COVID. Just as a frame of reference, if you have seasonal flu, that's 1 to 2. And if you have measles, it's 15, because measles is airborne, right? So this is a pretty transmittable virus compared to flu, right? So it would be great to test to see who are these asymptomatic carriers, and then if we get them, we capture them, we tell them stay at home so they don't infect anybody else. That may be beneficial. So probably high-risk patients, probably people who work in high-risk jobs. And it would be nice to get to a place where every 2 weeks, we can probably test most people, or people who really need a test. But the way, the way things are right now, that seems to be really difficult.
Right, right. I think everybody would be very happy to know eventually when it's safe to go get a haircut. I think a lot of people
exactly.
are really looking forward to that. Yeah. So, and there's another question. These are a lot of the same questions that keep coming up, and I think it's great. And so can you discuss the guidance on cleaning surfaces such as groceries or mail? There was some evidence about frozen foods and what to do if you put your food in the freezer.
Yeah, this is a good question too. So there was a study in New England Journal of Medicine about a month and a half ago that actually it was done in the lab. This study looked at different surfaces and they used PCR tests to say, okay, how long did they find COVID on these different surfaces? So on a copper surface, it was there for 4 hours. On cardboard, it was there for 24 hours. And steel and plastic, it was there up to 72, 96 hours, right? Then they had this machine like a drum that would push the virus out into the air to simulate a cough or a sneeze. And it said, well, it was in the air for about 4 hours. And the half-life decay was 1 hour. So every 1 hour, it would decrease by half. But you have to understand, there are two important things about that study. It was in a lab environment. And that's different from outside, the actual environment. There are a lot of shear forces that work on the virus, humidity, wind, UV light, that may degrade the virus, right? So the other thing about that study is it uses PCR. Now PCR looks at just a DNA. So if I have on this surface a virus that's broken open and it's dead, but the DNA is there, and I do that PCR test, it's going to amplify the DNA. So it's going to be positive. That doesn't mean that is a virus that is alive and it could be cultured and it's infectious. So when we see PCR results, we have to be careful how we interpret that. The general rule, and what I tell everyone and what we tell patients that call us, is at least 24 hours. So if, let's say, you get a package from Prime, from Amazon, and it's something that's non-perishable, and you can leave it in your garage for 24 hours before you open it, that should be fine, right? I think beyond 24 hours, it's safe. When you get your groceries, if it's something non-perishable, there are two things you could do. You could just leave it, in the kitchen, in the bag for 24 hours, and then you could take things out. If it's something that's perishable and has to go into the grocery, you could wipe it down. You could get a bleach solution, just wipe it down, and you can then put it away in the refrigerator. When it comes to frozen meats and stuff like that, the last time that was handled by anyone was probably a long time ago. So it's more or less safe. So for surfaces, or you get a package or groceries, you can wipe those things down, then wash your hands really well, and you should be fine. If you want to just keep it in its package, at least 24 hours is a good rule of thumb. After that, any virus on the surface is probably not viable. It's probably been degraded, and it's not clear that that's infectious. In any event, no matter what you do, before or I should say after you put everything away, you wash your hands, try not to touch your face. Those are the kind of precautions you should take. But I would say about 24 hours, that should be fine for packages and for groceries.
And remembering that anything inside the package is well beyond 24 hours.
Exactly.
So
Exactly.
the inside the package should be fine. So it should be very safe as long as you wipe down the surface. And nothing's going to transmit through your hands. So as long as you don't touch your face, you should.
Exactly.
Yeah. Right. Another person asked that as a person with underlying conditions such as asthma, diabetes, and heart disease, how should we be approaching the upcoming school year? My daughter is a junior in high school, and should we be concerned about sending her to school and potentially exposing me to the virus?
Yeah, this is a really important question. And it's going to be a difficult question to answer, not just for me, but for the people who have to make decisions about school. Because I think, and I don't know what they're going to do, but I think we could probably only open up school when we're pretty confident the numbers are coming down to a very low level. So I would think, just thinking out loud, we have to see probably, more than 14 days, probably a month of decrease in cases every day. And hopefully that will happen throughout the summer. We have to see probably the percent of tests that are positive be really low, 10% or less, before we can say we're going to open up schools. And then schools are probably going to have to find innovative ways to figure out how to have classes. So will it be that they'll have to split the class up and some students will go Monday, Wednesday, Friday, some will go Tuesday, Thursday, Saturday? We don't know. But I think the only time we could really safely open up schools is when we get some guidance, probably from the task force. And that will probably have to be when we see very low levels of positive tests, where schools can probably make changes to the classroom, where don't have as much students in the classroom, so people can kind of distance. And again, it comes back to the first question we had, right? What's going to be a risk? What's going to be a risk, and how do you calculate that risk? So if numbers are down in the community, if the amount of tests that are positive are down, if we could change up the classroom where we could probably social distance, and I know that may be difficult, we may have to have kids come to school on different days. Then if we deem it safe enough and it's and kids get to go back to school, I think the risk will be lower, right? Because we've taken all of these precautions, right? And then at home, we'll do the same things that we do now. Be very careful, wash your hands a lot, don't touch your face. And again, if we get to a place where we can test people more every 2 weeks, I don't know, can we test school teachers? Can we test kids? Then, we'll see if that's a possibility. To be honest, I don't know what they're going to do with schools. I don't know if they're going to open schools up. I think a lot of colleges have already said for the fall, they're going to stick to online classes. Because I think, again, when you talk about risk and you talk about a lot of people in an auditorium or in a classroom, the risk is going to be, higher. And so that's what we're going to be grappling with. So that's a difficult question. I'm interested to see what the task force will say about schools. And I don't know if we'll even really have school in the fall. That's yet to be determined.
Yeah, it's unfortunate and kind of scary, but it's also a microcosm for what's happening all across the world. Sports and concerts and workplaces and everything else. That's just one part of that big question. So, but obviously, school is a really important one. So, for any of those parents of school-age kids out there, just stay tuned. One of them, I'm worried about that as well. But we'll have to wait and see. And on a lighter note, somebody asked that I have been keeping my dog away from people, not because I'm afraid the dog will get COVID, but because I worry that the virus could be transferred from somebody's hand or to her fur and then to me, or vice versa. Is this a legitimate concern?
I would say yeah. So there have been cases of dogs and cats that have been tested positive for COVID. And if you go to the CDC's website, in New York, there's a dog that was tested that had some respiratory symptoms, got tested, was COVID positive. The owner was COVID positive. So potentially, if dogs or pets can be carriers, you don't want somebody to be petting your dog, or you don't want to be petting somebody's dog, because then if that dog is a carrier, you can then get it. And dogs, I love dogs. Dogs lick your face a lot, right? So that will be a mode of transmission that's, very, very high risk. So now, how long can it stay on fur? We don't know, to be honest, right? But I would say that's why prevention is as good as cure. I would just try to really not have anybody pet your dogs and stuff like that, and try to keep your pets away from others. I wouldn't, if you go to the CDC's website, they have a lot of, good guidance as to what to do with pets. If you're sick and you have a pet, you shouldn't, put a mask on a pet, that kind of thing. You shouldn't bleach down your dog, that kind of thing. There are a lot of good things there, but no, to be honest, there have been cases of pets with COVID, and so you have to be just as careful. That would be my advice.
Good, that's good advice. It's tough on the dog lovers and on the dogs too, I'm sure.
Yeah.
So, yeah. All right, and then another person asked, I keep seeing ads for UV devices to sanitize things like cell phones. Do these devices work effectively to kill COVID? If I use one instead of wiping down my phone, would that be adequate?
It's a good question. So we know UV light does kill the virus. Matter of fact, here in the hospital, we terminally clean rooms with a robot that has like a UV light, right? And that's very common in most hospitals. However, remember, those are commercially tested devices that work in hospitals. So home devices, I would not recommend using those. Now, UV light is also harmful to human DNA. So, they can increase your risk for cancers and stuff like that. And those home devices are not regulated. So you don't really know what you're getting, right? Is it giving you an intensity of UV light that's dangerous? We don't know. I think simply wiping down your phone with any kind of bleach product or bleach wipe or a dilute solution of bleach is fine. And if you don't have bleach, you could use any kind of isopropyl alcohol. Obviously, you don't want to do anything that could damage your device, but anything that's a mild solvent should be good enough. But I would be very cautious using these UV home devices because they're not regulated and they could be dangerous.
Or inadequate. They could be just not powerful enough. So
yes, exactly.
Security too. So on the other side, and that's a good point. Also, just to say that there, even before this all started, there were lots of studies to show that the dirtiest thing that you own is your phone.
Yes.
And so, wiping down your phone frequently, it's easy for us to forget. A lot of us think of it as an extension of our own body in some ways. And so, but really be careful. You wash your hands frequently, wash your phone frequently too. Because it's
absolutely
a great source of to spread disease. And I've seen this story come out a couple of times too. There was some speculation that the coronavirus weakened over the last few weeks or few months. Is there any truth to that story?
So I haven't read anything specifically about that. I mean, what we do know is UV light does affect it. So the hope is during the summer months, we'll see decreased cases. There was a study that showed that. I mean, that typically with viruses, they're not as prevalent in the summer months for a lot of reasons. One is humidity, UV light, also because everybody's all spread out. But yeah, I haven't read anything else about that. Now, when it comes to mutation of the virus, we're not seeing any significant mutations that we're worried about. So I think that's important. Now, all viruses will mutate to a certain degree because viruses, they replicate at a very high rate, more so than bacteria. So we're going to see some mutation. But the question is, are those mutations occurring at the part of the virus, like the spike protein, and these other very important structures where, we're pretty much developing our vaccines against. And we're not seeing that right now. Hopefully it remains like that.
Yeah, so I read something that sort of said that you're not seeing a lot of changes with it, partly because it's sort of a perfect virus. It stays around long enough for it to replicate itself and spread itself so well that there's not the pressure for it to replicate, to mutate, like some other viruses might. Another one with the summer coming, how can we stay cool this summer? Is it okay to swim in the pool or the ocean with others nearby? And how about spending time on the beach?
Yeah, I mean, I think it goes back again to risk. And I think swimming, I think being on the beach, I think being in a pool, that risk is generally low. All right. Where you're going to get into trouble when you do those types of activities, how many people are around. So if, it's like the protests that we see now all over the country. Yeah, everybody's outside. But that's a lot of people together shouting and not everybody's wearing a mask. That's high risk. If you're on the beach and you're not really around a lot of people, your risk is lower. right? And I think swimming, which is good exercise, and it's important for us to get exercise, being in pools, we don't have any information that tells us that, COVID is in water, and that's a big problem. So I think, plus pools are chlorinated, right? So that probably will offer some protection. So when you go out to pools or the beach, it's really the same general principles of avoiding crowds. But I think those activities, generally speaking, especially for the summer, would be fine. Once you could stay away from a lot of people, you could kind of social distance. I think those are lower risk activity. If you're around a lot of people on the beach is all crowded and there are a lot of people, then, there could be some risk there. But just being in the water, being in a pool, I think that's a lower risk.
Yeah, that's great. Another question, it says that in hundreds of communities across the country, there's a disproportionate number of minority people hospitalized with the virus. And it's also shown that they're also at high risk for getting it, I believe. Is there anything that minorities can do differently or more aggressively for themselves to help prevent the virus or be less likely to have bad outcomes?
Yeah, it's a good question. I mean, I think, it goes back to essentially the basics about protecting yourself, understanding the risk of certain activities, right? So being outdoors, social distancing, washing your hands a lot, being really careful with the things you do. Those are probably the best things that you could do to protect yourself. We do know certain things about the virus. We know it can't jump from me to you if I'm six feet away from you, right? We know if I wear a mask and you wear a mask, we're pretty much protected. So I would focus on the general, simple kind of infection prevention behavioral patterns of washing your hands a lot, staying away from a lot of people, trying to social distance, try not to touch your face. That's the best way that you can protect yourself. When I go to the grocery, I try to go at off hours. So I go to Harris Teeter like Saturday at 7 a.m. I go in and out, right? If I have to go to Home Depot, I go like late at night. So there are certain things that you can do if possible, right? Not everybody can do that. But it's a matter of just trying to be really careful and as careful as you can. And that's probably the best way that you could protect yourself. If you have comorbidities, we know if you have underlying lung, heart disease, diabetes, age over 65, you're at higher risk. So especially that population of patients, just be really careful. I had a patient that was going to the grocery twice a week. And so I was like, well, is it possible for you to go like once every 10 days or try to buy enough stuff? And she was like, yeah. I was like, okay, let's try to do that. And her husband was 85 and she was pretty healthy. But just little things like that, make these little changes. If somebody comes into your house, make sure they're wearing a mask and you're wearing a mask while they come in. There are a lot of patients I have who had people coming to clean their houses. They stopped that for now, right? Little things like that. So they had a housekeeper that would come in once a week. Stop that. So these are little things that you can probably potentially do to try to decrease your risk, especially if you have these risk factors for getting infection.
Yeah, great. That's great. And then we had some chat questions as well as we've been going. Somebody asked, is there any progress on the rapid tests? I think that would be really helpful.
So we have a lot of rapid tests. Here at VHC, we have the Abbott rapid test, which we get in 30 minutes, we get a result. Quest, they have a rapid test. Our turnaround time is typically 24 hours. Roche, there are a lot of rapid tests. What we would want to see is a rapid home test that is, again, the performance is good, it's believable, the sensitivity, the specificity is really accurate. But I think we're far away from that, to be honest. There was some data on a saliva test, but that saliva test, the study that was done, it was on really sick patients. It wasn't like an outpatient with mild symptoms. So I don't know how, that data will translate to somebody who has mild infection. Would the test be as good? So the rapid test, the good news is we could get a result quickly, but again, sensitivity, specificity becomes an issue. And so even though you do a test, a rapid test, you have to be able to interpret the results. So somebody may have symptoms and the test may be negative. Is it truly negative? Is it early on in the disease course that it's not positive? Is it that they have infection in the throat and I'm doing a nasal swab, right? There's just so much variability that we don't know. So right now we have a fair amount of rapid tests. We have a rapid test here at VHC. The question is the performance, and we still have to interpret the results. Hopefully we could get to a point where we have a home test that's really sensitive and specific that people can easily do. Something like a pregnancy test, right? That really performs well. And it'll be a while, I think, before we could get there.
Right. Or like a flu test, something that we could do in our office too. Right?
Yes, exactly.
Along those lines. Somebody asked also, is isopropyl alcohol isopropyl alcohol products effective for wiping down surfaces, or do we can I just use a water solution with detergent? I also asked about bleach. You know, are there any specific cleaning agents that are better than others? Yeah,
so bleach will kill the virus readily. I think if you have a bleach solution, that's the best, right? So normal Clorox, and if you go to the CDC's website, they tell you it's like 4 teaspoons in a quart of water, and so you can mix up very dilute, right? So bleach would be the best. Any alcohol product with at least 60-70% alcohol would be fine. And if you don't have those, any detergent will work. So something is better than nothing. So a detergent will be better than just plain water, right? But even like laundry detergent, anything that you have that has some kind of antimicrobial property will be fine. But if you have bleach and you could have a dilute bleach solution, that would probably be the best solution to use to clean surfaces.
Great. And does blood type have any suggest any greater susceptibility to this, or for getting it, or for having bad outcomes?
Yeah, that's interesting. You know, I don't know of any specific data that I can recall mentions anything about blood type, to be honest.
Not either.
Yeah.
Interesting question, but I haven't seen that. No.
Yeah.
Are there any conditions that you would recommend, thinking that it's safe for someone to go visit someone in an assisted living facility?
So as you probably know, in Virginia especially, we have a lot of outbreaks in nursing homes. And, you know, obviously that's because of the patient population there, you know, the age, etc., comorbidities. So until we really get down to very low numbers, and probably the governor will give us some guidance on when we can start visiting, you know, our family members in nursing homes. I think at this point that's going to still be risky, to be honest. Until we have, you know, evidence that those outbreaks are actually diminished to the point where we don't have as much cases, then I think, you know, in the meantime, that's going to be difficult. Most of the nursing homes had up to 40-50% of patients from some studies that I looked at were asymptomatic. So one study out of Washington State looked at, they tested all, everyone in the nursing home, out of 50% had a positive test. So until we could get that down to a really, really low number, I think it'll be still very risky to visit people in nursing homes.
Right. That's a tough one. Yeah. And then I think when we make this our last question, as we're sort of running out of time here, somebody asked, what, if any, role does vitamin D play in association or causation with COVID?
COVID, yeah, that's an interesting question. I haven't read anything in particular, but you know, there's a lot of data about vitamin D, even without COVID, right? It's associated with dementia. It could be associated with different diseases. I have not read anything specifically about that. I don't know if you have seen anything about vitamin D and COVID, but I haven't read anything particularly about that.
What I read is that there is an association of lower vitamin D with bad outcomes. But there's an association of lower vitamin D with bad outcomes in many, many diseases.
Yes.
Partly because people who are infirmed and who are sick already aren't outside in the sun, or not, or malnourished, and are more susceptible to having a lower vitamin D. So it's an association, but not necessarily causation. Yeah. I haven't seen anything specifically that says low vitamin D will result in poorer outcomes.
Yeah, I have not seen that. Yeah.
that because of the vitamin D or that vitamin D supplementation will result in better outcomes either. We haven't seen that either. So, but it makes sense that there is an association. So, all right, well, great. That was really helpful. I hope it was helpful for everybody else out there, but that was really very, some great answers and to a tough situation that everybody here is dealing with. And I really appreciate you taking the time and answering our questions for us. I know you have a lot going on right now, taking care of a lot of these patients in the hospital. And so I really appreciate you taking your time and sharing your knowledge and your experience with us. And so,
yeah, me too. Dr. Zweig, could I ask a question?
Doctor question? Absolutely, of course. Yeah.
Dr. Seemungal, we're trying so hard to keep people out of your hospital. Yeah. And I would love to know if there's any new advice for us to be using anything like outpatient steroids, or are we saving those for people who are hospitalized? I know that's something that they're using earlier in the hospital. Is there anything we can do for your outpatient COVID patients?
You mean as far as treatment?
Right.
Yeah, unfortunately, no. You know, especially steroids and anticoagulation, those protocols are really for hospitalized patients.
Yeah.
So I haven't seen any data on, you know, anything specific for patients in the outpatient setting. Mm-hmm. What we advise if a patient is in the outpatient setting but stable, that they kind of self-isolate, treat symptomatically, keep up on fluids. If they have a pulse ox monitor, that may be useful for them to have to just check their oxygenation status. Tylenol for fever, you know, that kind of thing. And hopefully as time goes on, about 7 days, 10 days, they start feeling better. They have no fever for about 72 hours, then that means that they're actually getting better. But there isn't anything specific as far as a therapeutic beyond that, that we know of that, you know, we would give or recommend for outpatients.
Well, it just doubles and triples our already enormous gratitude to all of you who work in the hospitals, because we're able to coach at home, but you're the people who are able to treat it. So it's so great to talk to you. You're absolutely fascinating. I'm so grateful that Dr. Zweig knew you and was able to invite you. And thank you so much for the work that you're doing, keeping everyone as healthy as possible in the inpatient setting.
Thank you. Yeah, and I'm happy to be here. And if you guys have any questions and stuff like that, you should always feel free to call us and let us know, because we're always happy to help.
I found that's always been true, so I really appreciate that. And from, as she said, thank you very much for really, you know, putting yourself on the line and doing really hard work being in the hospital. It's scary and it's difficult, but it's necessary. And I really thank you for doing that work.
Thank you. Sure.
Great. All right. Well, thank you so much for your time, and appreciate that. And I hope this was helpful for everybody. Hope you all have a good night and be well.
All right. See you.
Thank you.
All right. Bye.